We combine the talk for neoadjuvant adjuvant therapy by Javier Cortes from Spain.
So thank you so much, Sibyl, Olivia, and also the scientific committee for inviting me to be here today and to talk about a disease which I think is quite hard. These are my disclosures. So it's hard to work with a disease which is defined by being negative, negative, and negative. Just in the Bible, some important people said twice negative, negative, negative to Jesus Christ. So this is not a good way to start. Nevertheless, I would like to ask something to the room. If you have a patient which is ER 1%, PR 0%, and HER2 negative, and she has metastasis, would you treat this patient with triple negative based treatment, or would you treat this patient with endocrine based therapy? So my first conclusion is that I think that we have to think about the definition of triple negative breast cancer, and I'm not sure if this is the best way of moving forward. Let's go back to the biology. And I think this is one of the most important papers in terms of biology published by Aleix Prat in The Oncologist some years ago, showing that there is about 20% of patients that maybe do not have the same behavior compared to that classical triple negative, or I would say classical basal-like tumors. And it is true that when we compare how those tumors, which are triple negative based on immunohistochemistry, but are HER2 enriched based on the gene expression, are more similar to the patients who have tumors that are luminal B or HER2 overexpressing tumors. So maybe there is time to change this in another, to think about this in another way. Look at the expression of different proteins and compare triple negative and non-triple negative based on the genomic profiling. Of course, if you have a patient with this HER2 overexpressing, she overexpresses HER2. That makes sense. But in terms of biology, the behavior of these tumors, triple negative and non-triple negative but HER2 enriched, is very similar. And the same with the other different proteins. So again, I think that this something is not ready for the clinic. That's very clear. We have to rethink if the next prospective clinical trial should be based on biology or just based on immunohistochemistry. Of course, it's also a matter of prognosis. Patients with basal-like has much worse prognosis or HER2 enriched compared with patients with luminal-like tumors. And also, this something has been observed with other platforms, such as the one published by Lemans and colleagues. The heterogeneity of triple-negative breast cancer is not just based on genomic profiling, but also based on histology. And as you can observe here, and this is something we observed in the clinic, there are different groups of patients, some of them with horrible prognosis, very similar to lung cancer or even pancreatic cancer, and other ones which are quite very similar to prostate cancer or classical luminal breast cancers, apocrine tumors and others. So not only is a problem, it's a matter of biology, also this is something we can observe in the clinic every day. So let's start with the neoadjuvant approach. And this is just one of the 3 most important studies comparing outcomes for patients who achieve PCR and non-PCR, and this is very similar to the HER2 positive field. Patients who had PCR will have much better outcomes comparing to those patients without PCR. Similar data in the CALGB trial and similar data with the I-SPY trial. However, those patients who do not achieve PCR but have a very good pathological response, according to the residual cancer burden, also benefit and have also very good outcomes. That's why, in my opinion, not only classification patients for post-neoadjuvant trials based on PCR is a good way of doing it, maybe we have to consider the amount of residual disease. This is something we should consider for future clinical trials. What about pathological complete response? There are some factors that might predict that. One of them, which is some of the most interesting ones, in my opinion, is the amount of tumor-infiltrating lymphocytes. We know that in triple-negative breast cancer, the higher number of TILs correlate with the higher probability to have pathological complete response, not only for PCR, but also for prognosis after neoadjuvant treatment. Patients who enrich the tumor with TILs have also better outcomes compared with those patients who did not have an enrichment by TILs. What about treatment? Let's start with the platinum compounds. And in my opinion, these are the two most important trials. One of them run in America, the other one in Europe. Different clinical trial designs, different conclusions. So at the end, I don't know if we have enough data to say that platinum compounds should be added to the neoadjuvant standard treatment to all patients or not. One thing that should be discussed before, in GEPAR 6-2, patients received chemotherapy with or without carboplatin, but all patients received bevacizumab in the neoadjuvant setting. This is something, unfortunately, bevacizumab is not a standard of care, so this trial, I don't know how we can move forward with that. In the CALGB, some patients received, some other patients did not receive bevacizumab. Results with GEPAR 6-2 clearly improved PCR, and also very interesting data in terms of disease-free survival. However, according to the CALGB data, very nice pathological complete response rates, also clearly improved by 15% absolute numbers, but it did not translate into an improvement in long-term outcomes. So if you compare both trials together, I think it's difficult, in my opinion, to make conclusions. Carboplatin was weekly in one of the studies. It was every 3 weeks in the other. Again, in one study, all patients received bevacizumab, not in the other one. So can we translate these results into the clinic? I will make a comment at the end on my talk about that. What about the BRCA status? This is something surprised me a little bit at the very beginning when we saw this data. You can observe here that patients without BRCA, germline BRCA mutations did benefit clearly in terms of PCR with the addition of carboplatin. This is something we did not observe for those patients who had germline mutations. Maybe because these tumors were very sensitive to anthracyclines, could be. So maybe in the presence of anthracyclines, adding platinum compounds is not good enough. Or maybe because it's not a problem about germline BRCA mutations. It's a problem of phenotypes. And maybe those patients who are or who have BRCA-like cancers behave in a very similar way. And that's why in those patients without these mutations, but also have this phenotype, had the same benefit from carboplatin. So I don't know which is the data. We will have some trials that are going to try to answer this question. But at this time, in my opinion, we do not have enough arguments to say if we want to add platinum compounds that we have to do it in one group of patients, but not in the other. What about Nab-Paclitaxel? We also have beautiful data with Nab-Paclitaxel in the neoadjuvant setting. 2 clinical trials, one of them is GEPAR 7-2. It's a very pragmatic trial, weekly paclitaxel or weekly Nab-Paclitaxel followed by anthracyclines-based therapy. Very good data in the total population, but very, very impressive data, in my opinion, for the triple-negative group of patients. The pathological response moved from 26 to 48%. And what is much more impressive, it clearly translated into a not significant, it was not the primary endpoint of the trial, but something very interesting in terms of disease-free survival. However, the Vienna trial came out afterwards. Same idea, paclitaxel compared with Nab-Paclitaxel, 1.2 raised. Here, the paclitaxel arm was 3 weeks on, 1 week off, which is not the classical standard of care. Is it important for the consequences of the trial? I don't know. But the truth is that even in triple-negative breast cancer, pathological complete response was very, very similar. So once again, 2 trials which are quite nicely designed, not very similar results, so it's difficult to translate the use of Nab-Paclitaxel into the clinical practice, in my opinion, to the total or to all patients. What about both agents together? What about Nab-Paclitaxel and carboplatin? I think this is a beautiful trial in which we try to compare Nab-Paclitaxel gem or Nab-Paclitaxel carboplatin. The results, and my take-home message is that without anthracyclines, carboplatin plus Nab-Paclitaxel produce 50% pathological complete responses. So maybe for those patients who have allergic reactions or have a lot of hyperglycemia, this is something we might consider in the clinic. What about PARP inhibitors? We also have some data in the neoadjuvant setting, and I love this platform, the I-SPY trial platform. This paper was published by Hope in New England Journal of Medicine, and unfortunately, it did not answer the question about the PARP inhibitor because it compared standard chemotherapy or standard chemotherapy plus carboplatin plus beliparib. And the goal of this trial is to try to understand which is the probability for this new strategy to be successful in a randomized phase 3 trial and to be successful afterwards. And they said the probability this strategy to be superior is 99%. So let's do the randomized phase 3. And we did it. And the trial compared here the PARP inhibitor plus carboplatin or standard chemotherapy. And what we observed is that the trial was positive for the strategy we tested in the I-SPY, but maybe it was because of the carboplatin compound and not because of beliparib. So unfortunately, so all these platforms, I think, are very, very interesting, but in the future we have to move forward with clearly questions to be answered afterwards in the randomized phase 3 trial. What about other compounds? Talazoparib is a specific PARP inhibitor with different properties. I will not go into enter into detail. Only 20 patients treated with talazoparib single agent in the neoadjuvant approach. Very, very interesting data. All these patients did have BRCA mutations, germline BRCA mutations. 15 patients did have triple-negative breast cancer. 5 patients did have hormone receptor-positive tumors. 1 out of these 20 patients was not analyzed because she did not want to undergo surgery. Nevertheless, 10 patients did have pathological and complete response, and 2 patients had a very, very good response. In total, 63% residual cancer burden, 0 or 1, which I think could be very, very interesting. Based on this data and others, the GEPARO last study, I think is very, very, very aggressive trial. If I have to bet, forgive me about this, I'm not sure if this is going to be positive. Paclitaxel carboplatin, paclitaxel olaparib, followed by anthracycline-based therapy. So this is the first time we are going to compare carboplatin and PARP inhibitors. In combination with chemotherapy, that's fine, but it's going to be the first time. I don't know if this will be positive or not, to be very honest, but nevertheless, should be done, so I would like to congratulate the investigators for this amazing, amazing trial. What about immunotherapy? We also have some data with immunotherapy, some data with palbociclib, very quick, very nice pathological and complete responses in a very small phase 1 trial, presented by Peter Smith at ASCO last year, and also, based on the I-SPY platform, makes sense to explore the role of palbociclib, of pembrolizumab, in patients with triple-negative breast cancer in the neoadjuvant setting. We also have some data with another immunotherapeutic compound, with durvalumab, and a PD-L1 inhibitor, also with very nice responses. My question here, is it interesting to give the PD-L1 inhibitor before starting with chemotherapy or not? If this is the case, why not to optimize the immune approach before chemotherapy, not only with the PD-1, maybe also combining with that CTLA-4, just to be able to enrich the tumor with tumor-infiltrating lymphocytes before treating these patients with chemotherapy? Well, I don't know, many questions to be answered, but the point is that immunotherapy might be of interest to treat patients with triple-negative breast cancer. 2 important randomized phase 3 trials, which are upcoming, one of them with pembrolizumab, the other one with atezolizumab. We will have data with the Keynote 522, hopefully by the end of this year. Let's move into the adjuvant approach during my last 5 minutes. Again, tumor-infiltrating lymphocytes is also important in terms of prognosis. Patients with higher tumor-infiltrating lymphocytes did behave better compared with those patients without a high amount of tumor-infiltrating lymphocytes. Let me stop here for a minute. We have been talking many times to escalating treatment, de-escalation of treatment, more agents, less agents, more chemo, less chemo, better surgery, better radiation therapy. What about the time between surgery and chemo? This is a beautiful retrospective analysis conducted at MD Anderson, and they observed basically that we have to start chemotherapy as soon as possible. And this is something we observed also in South America. Look at this data. Patients with triple-negative breast cancer who started adjuvant treatment during the first month of disease distant metastasis-free survival at 10 years was 80%. If we delay the start of chemotherapy, it decreased to 65 or even to less than 60%. So it questions me something. I know that chemotherapy followed by surgery is similar to surgery followed by chemotherapy. But if we start with neoadjuvant treatment, we will start with systemic therapy as soon as possible. So would it be possible that in triple-negative breast cancer, the neoadjuvant approach is not only good for many issues, but also to improve long-term outcomes because we are not delaying the start of therapy? This is something we should think about in the future. And that's why, in my opinion, even with tiny tumors, I would like to start with neoadjuvant treatment before surgery, even though we have not shown that it might improve outcomes. What about the post-neoadjuvant? There are different issues here. It could be good for patients with non-PCR high-risk subgroups. This is something was commented before very nicely. We can discuss about the type of residual disease we might have. So maybe we can change the treatment we are going to use. You all know this data. Capecitabine after non-PCR for patients with triple-negative and non-triple-negative breast cancer. These are the data of triple-negative breast cancer. Unfortunately, these patients were not pretreated with platinum compounds. So is it valid for patients who received carboplatin before? I think we are not going to have the answer, but we will have the patient in the clinic. So in my opinion, CAPE is quite cheap. The toxicity profile is not bad. So I think that we have to talk to the patient, that's clearly, but I would consider for patients at least with a high residual disease, I would consider to use CAPE, even the patients received or not platinum compounds. This is a beautiful paper showing a couple of things. One is that the majority of patients with residual disease will also have basal-like tumors, which are quite sensitive to platinum compounds. And that is why I think this trial makes a lot of sense. It's a beautiful trial. Patients with non-pathological complete response after chemotherapy will be randomized to CAPE or platinum compounds. Beautiful trial that we'll see the results in the future. Another point, based on the residual tumor, studying this from a genomic point of view, can we use different targeted therapies to optimize data for these patients? This is the purpose of the 152 trial, which is being running. Two more trials, and I will finish, which I think is quite important. One of them is to explore also the role of immunotherapy in patients with residual cancer after neoadjuvant treatment. And the last one, of course, it's also very important to explore the role of PARP inhibitor in patients with high-risk tumor and germline mutations. Once again, my question here is, what about for those patients who received platinum compounds before, even though they do not have a pathological complete response? Are we going to add something, anything, with the role of PARP inhibitors or not? So, just to conclude, I think that we have different trials with platinum compounds, with different taxanes, which has shown clearly to improve pathological complete response, but we do not have clear answers for disease-free survival. So my opinion, for some patients with very high-risk tumors, young women, no comorbidities, we can at least discuss the use of platinum compounds, maybe for patients with hyperglycemia or patients with allergic reactions to taxanes. I think Nab-Paclitaxel could be also a drug to think about. PARP inhibitors, we still do not know which is going to be the role, but I think that maybe for a group of patients, de-escalation might make sense with this 50% of pathological pre-response for patients with germline mutations. Great activity with immunotherapy. Let's see if PD-L1, PD-1, and we can find a biomarker. But the great point, again, as we observed in HER2-positive disease, which is the delta value we have to get to translate into real benefit in disease-free survival. Because if we do not answer this question, it's going to be difficult to discuss or the future clinical trials in terms of PCR to be the primary and the unique primary endpoint to approve new drugs. Finally, let's start chemotherapy in the adjuvant setting as soon as possible. CAPE should be considered, even if carboplatin is not used, at least discuss with the patient. And the future of clinical trials is there, and I hope that this negative disease will be at least one of them positive. That's all. Thank you.